Hello everyone, in this video we are going to discuss about pneumothorax. So what is pneumothorax? The presence of air in the pleural space causing lung collapse is called as pneumothorax. So pneumo means air. Pleural space means the space between the visceral and the parietal pleura. So whenever air enters this space and causes lung collapse, it is called as pneumothorax. Coming to the types of pneumothorax, first type is primary type. Primary means there is no underlying lung disease. It occurs in young thin males and also in smokers. Secondary pneumothorax, there is underlying lung condition which is leading to pneumothorax. The conditions like COPD and cystic fibrosis can cause this. Traumatic type, as the name suggests, it is caused either due to blunt trauma or any penetrating lung injuries like any rib fractures causing pneumothorax. Next is iatrogenic type. That means any medical procedures like central line insertion or any mechanical ventilation which is leading to pneumothorax. The fifth type is the tension pneumothorax. Here air enters the pleural space and cannot escape. So the one-way valve mechanism occurs. So there is increase in the air accumulation in the pleural space causing increase in the intrathoracic pressure. So leading to the collapse of the lung and compression of the heart and also great vessels. So there is decrease in the venous return and also patient will have hypotension. So normally the pleural space, that is the space between the visceral and the parietal pleura, there will be negative pressure. So this negative pressure means the pressure is lower than the atmospheric pressure. So this will keep the lung expanded. So whenever the air enters this space, the negative pressure is lost. It is either neutralized or it is converted into positive pressure, that is more than the atmospheric pressure. So the lung expansion is lost and the lung will collapse. So here in this picture we can see this is the normal lung and the pleural space. On the left side, on the right side, we can see there is a lung collapse. As soon as the air enters the pleural space, the lung will collapse because of the loss of this negative pressure. So clinical features include there will be sudden, sharp, pleuritic chest pain along with dyspnea, decrease or absence of breath sounds on the affected side, and hyperresonant percussion and decrease in the chest expansion, and sometimes you can see subcutaneous emphysema. So tension pneumothorax, there will be hypotension because of the decrease in the venous return because of this compression of the great vessels, and tracheal deviation will be seen away from the affected side. So whenever there is left lung pneumothorax, the trachea will be shifted towards the right side. So in this picture we can see there is right lung collapse, right lung pneumothorax. So the trachea will be shifted towards the left side. Next is there is distended neck veins, that is increase in the JVP we can see. Diagnosis is by chest X-ray. There is visible pleural lines with absent lung markings. So in the above picture of the chest X-ray we can see there is absence of the lung markings. There is right-sided pneumothorax, and here we can see the visible pleural line. Next USG we will see a lung point sign. So lung point sign it is seen in the ultrasound. It is a transition point where the normal lung sliding, that is the attached lung meets the absent lung sliding, that is the collapsed lung. So it is highly specific for the pneumothorax. Next is CT chest. It can be done for any small pneumothorax. So we have to assess the severity first. We have to see whether it is less than 2 cm or more than 2 cm. It is if it is less than 2 cm, it is smaller one. So there will be only mild symptoms. It is more than large thing, that is more than 2 cm or any severe symptoms are there. We should always assess the tension pneumothorax also, where there is hypotension, tracheal deviation away from the affected side, and also shock, and distended neck veins because of the increase in the JVP. So if it is small and stable pneumothorax, 100% oxygen therapy and observation with repeated chest X-rays can be done. If it is large but stable pneumothorax, then needle aspiration, we will insert a wide bore needle or a catheter in the second intercostal space mid-clavicular line. So here we can see second intercostal space mid-clavicular line. We will do a needle aspiration, and if the aspiration is failed, we have to insert the chest tube. In secondary spontaneous pneumothorax, immediately we have to insert a chest tube at the fifth intercostal space anterior or mid-axillary line. In cases of tension pneumothorax, emergency needle decompression is done first. Insert a large bore needle into the second intercostal space mid-clavicular line, following by a chest tube at the fifth intercostal space mid-axillary line. So here we can see chest tube insertion at the fifth intercostal space mid-axillary line, and underwater seal is done. So chest tube management, chest tube is actually connected to an underwater seal or suction, and we have to monitor for any air leak or lung re-expansion. and we have to do a follow-up series of chest x-ray should be done. Once the no air leak is seen and the lung is fully expanded, we can remove the chest tube. So here we will see the mechanism of this underwater seal. So at the fifth intercostal space, the chest tube is inserted and it is sealed to underwater seal up to a 2 centimeter level. So here what it does is the chest tube is connected to the pleural space, partially filled with water, that is the drain. So whenever the patient will exhale, the air from this pleural space will enter the tube and will be went through the second tube. So whenever the patient inhales, the air from the atmosphere will not be able to reach here. The water will act as a one-way wall and air can exit through the bubbling but cannot re-enter the pleural cavity. So this will prevent the collapse and helps in re-expanding the lung safely over the time. So here we can see on expiration the air is moving away, moving out from the pleural space. On inspiration it is not entering through this atmospheric air. So this acts like a one-way wall, and this is reverse to the one-way wall mechanism of the tension pneumothorax, where the air is entering but not exiting. Here the air will not enter but it will exit through the space. So it will help in re-expansion. So here the lung is smaller. It is this underwater seal in helping the re-expansion of the lung. So prevention after the recurrence can be done with pleurodesis. That is, we will attach both the visible and the parietal pleura can be attached mechanically or chemically. This pleurodesis, and the patient should avoid air travel until the complete healing is occurred, and smoking cessation is crucial in these conditions. So this is the pneumothorax and important points in the pneumothorax.